trip, so 80 patients walk into your pharmacy in a typical day. What percentage of those patients require a little bit extra due care and attention because of metabolic syndrome generally, or specifically because of their issues related to their diabetes?
So what percentage, and I want to step back just for a second to some of these, what I'm hearing is exactly what we're seeing in practice, is that the solution here to this mega problem is not always clinical. We've got that part figured out. We've got guidelines. We've got all these things that we can solve this problem with. But the major barriers we see are non-clinical issues. They are, how expensive is this food? And so that's where in the community pharmacy space, we're spending a lot of our time not only reinforcing guidelines and looking at these, looking at metabolic syndrome as a whole and focusing on, making sure the blood pressure's at goal and the A1C's at goal and the lipids are at goal. But in order to get there, you're not going to get there just with medicine. You're not going to get there, and when you get there, you don't get there because then there's always tomorrow. You're never adherent. You never say, "Oh, my patients are at goal." Well, really, they're not. They're at goal today, but they're not at goal 2 weeks from now. So it's constant reinforcement, bringing the family in, support group atmospheres, short baby steps towards goals. We had a patient walk in not too long ago that had been diagnosed with diabetes, A1C through the roof, lipids through the roof. We found out what they were doing is they were consuming over a case of soda soft drink a day. And so what they heard was, you've got to stop this, stop all white foods, stop all, stop. So they walked out not only with diabetes, but they walked out with depression as well and didn't know what to do. So our perspective is, let's slow down. Let's reduce this soda intake by, say, 10% a week. Let's work our way into a short-term goal process instead of just stop. We think that's more sustainable. So it's not always clinical.
So what I hear you describing then is not only patient walks in with diagnosed diabetes, that it's not just about that patient that you're trying to influence then, but it's also the environment and the patient's caregivers, family.
We invite family to support. We have diabetes support groups once a month in our pharmacy for this very reason, and we invite family specifically.
This feels a little bit like smoking cessation too, right?
Which
is behavior change. Right. So all of this is wrapped in, but what I'm also hearing you say is that there's such a long time horizon to this too. So if a 35-year-old walks into your clinic, hey, you're newly diagnosed, type 2 diabetes, you're gonna have a conversation with them not about, here's what we're gonna do next week, and then your problems go away. Right? You're having a conversation about, this is going to be a multi-year, multi-decade, perhaps experience. We're having to ask these patients to change their way of life.
I think what you mentioned to that point is very important, that it's the frequency of touch points and that behavior change has to be really, really small, because if you think about the time that they get in clinic, it's about 6 to 7 minutes is what the US average is. And so over the course of a year, you multiply that, if they have 3 to 4 visits, it's a couple hours. You're awake for about 6,000, so there's about 5,998 hours there at home. And so that's why, again, the community pharmacy, the extension, where they spend majority of the time, no one's engaging these patients, and we're spending a lot of time and resources in the 2 to 3 hours when they're in the health system, or at the hospital, or at the visit. But if we could spend more of our time engaging outside, I think that's where we're gonna make a huge impact in chronic conditions, specifically something like a diabetes.